Again, it encompasses several different diffuse pulmonary diseases, chronic bronchitis, asthma, and emphysema. You will have the patients that'll say, "Hey doctor, I don't got that COPD, do I? I got emphysema, but I don't have COPD, right?" So again, COPD is kind of the big heading. Breaks down into bronchitis, emphysema, chronic asthma. Okay. Progressive development of irreversible airway obstruction leads to limited airflow, leads to impaired gas exchange. Again, 10 to 20% of adults, 14 million people have chronic bronchitis. 2 million people have emphysema. Most of those are in Oklahoma City. Fourth leading cause of death in the U.S. COPD definition: chronic airway inflammation, airflow limitation, not fully reversible with bronchodilators. Minimal variability in day-to-day symptoms, slowly progressive and irreversible deterioration of lung function, leading to progressively worsening symptoms. They can be fine today, give it a few months, few years, it will gradually catch up to them. Okay? Risk factors: obviously smoking, typical, greater than 20 pack years. Again, cannabis has become a big question mark in my office. It's more prevalent nowadays, or I guess they're more open about it. One joint equivalent to about 2.5 to 5 cigarettes. Severe viral pneumonias early in life. That's why I always ask them about early childhood. Did you ever have a respiratory illness that got you in the hospital? Age, airway hyperactivity, exposure to dust chemicals, pollution. Early in the stage, again, they may not have any symptoms at all, but as it progresses, you'll get 2 patterns: chronic bronchitis or emphysema. In the differential, chronic bronchitis, bronchiectasis, asthma, bronchiolitis, and emphysema. I think in restrictive, I may go over bronchiectasis a little bit, and bronchiolitis. Bronchiolitis is true allergic reaction in your airways. Okay? Smokers' bronchiolitis, they truly have an allergic reaction to the inhaled smoke. Okay? Pathology, again, varying degrees of chronic inflammation of the small airways, chronic bronchitis, destruction of alveolar walls, mucus gland hyperplasia, squamous metaplasia, all chronic bronchitis and emphysema. Okay? You cause a lot of hypersecretion, leading to chronic productive cough. One of the main complaints of chronic bronchitis: loss of ciliary function leads to impairment of normal function of the mucociliary escalator to get out the bad stuff. That's really what that means. Okay? Chronic inflammation and fibrosis, small airways. Again, characterized by CD8 lymphocyte, macrophage, neutrophil infiltration with release of pro-inflammatory cytokines. Again, several different cytokines. It goes back to that inflammatory process. Recurrent infections may perpetuate airway inflammation. Emphysema, due to alveolar wall destruction, causes irreversible enlargement of air spaces distal to the terminal bronchial acinus, with subsequent loss of elastic recoil and hyperinflated lungs. There's different types of emphysema: panlobular, centrilobular, paraseptal. Panlobular, exactly what it stands for, pan, all over the place. Centrilobular, more central, occur with dilated air spaces found in association with respiratory bronchioles. Paraseptal, dilated air spaces at edges, abutting of fixed structures such as pleural or a vessel. COPD, emphysema gets bad enough, thickened pulmonary arterial wall. Watch out for pulmonary hypertension and pulmonary arterial hypertension. There is a difference. Don't ask me what it is, because it's a lot of big words. Okay? Increase in airflow resistance. Again, multifactorial. Small airway inflammation reduces airway lumen. Secretions may be present in airways. Emphysema destroys the radial attachments to small airways. I'm a big picture person. Okay? Narrow bronchial alveolus becomes enlarged, loses its structure. The way I kind of educate my patients on that, you have millions of little air sacs. You make them mad enough, they're going to retire very early. When they retire early, they need a buddy to hang out with. Right? They talk their other buddy into quitting. He talks his buddy into quitting. Next thing you know, you have a lot of little air sacs hanging out, not doing anything. Emphysema. Okay? Right? Am I right? Yeah. Very basic stuff. Okay? All right. If you look, normal lung, air exchange occurs in the alveoli. Millions of those little bad boys. Okay? Air exchange becomes difficult in damaged alveoli. Look, you lose the structure. You lose the structure. Air becomes trapped. Can't get it out. COPD/chronic bronchitis. Increased sputum production, more purulent sputum. I know, I do lung office. I gotta talk about spit. What color is it? It's thick, yellow, green, blue. What is it? Is it blood? Okay? They will usually tell you. My favorite, they will show you. Okay? Here, Doc, I brought this for you this morning. Progressive shortness of breath. One of the complaints you will hear a lot is, I can't do what I used to. This decreased exercise tolerance, or hey, I used to mow the grass, now I can only get about 2 strips and I'm done. Okay? Wheezing, chest tightness, non-specific symptoms, malaise, just tired all the time, they can't breathe. Okay? Symptoms, depending on severity, increased respiratory rate, hyperexpanded or barrel chest, prolonged expiratory time greater than 5 seconds. They worry about losing their breath. So they'll take a breath in, but they're very prone to hold on to it. Okay? There you go, the pursed lip breathing. Use of accessory muscles, respiration, diminished breath sounds, possible crackles, rails. You'll hear that in emphysema. Next time I do this lecture, I'll have sounds between emphysema and fibrosis. There's a subtle difference. Next time I come, you'll have sound. All right. Signs of poor pulmonale, ankle edema, raised reduced pressure, bounding pulse. Going through COPD, mild, moderate, severe. Look at FEV1, FVC. Greater than 80, mild, in between 50 and 80, moderate, greater than 30 but less than 50, severe, very severe, less than 30, what used to be called end-stage COPD. Okay? Chronic bronchitis, increased mucus production, recurrent cough, present on most days for at least 3 months out of 12 during at least 2 consecutive years. Okay? It's in red for a reason. Okay? Increased sputum production is a result of mucus hypersecretion, enlargement of seromucous glands, tracheobronchial tree, increased density of the glands. Easy presentation. Productive cough. I get bronchitis 2 or 3 times a year, and it lasts X amount of time. Okay? Coughing up blood. When they say that, you should have follow-up questions. They ever say they're coughing up blood? Always ask, how much? Teaspoon, is it flecks of blood? Is it stringy or streaks in your phlegm blood? Okay? Is it bright red? Is it dark? Is it a teaspoon, thumb, or tablespoon? How often does it happen? Okay? A lot of times you get chronic bronchitis, a lot of inflammation, small vessels in your airways. They love to tear when you cough so hard. Sometimes they'll cough up a little blood, but it won't happen for again for a couple of days. Or if it does, maybe it'll be a little bit darker on that 2nd or 3rd day. Cyanosis or hypoxemia, wheeze or what may or may not be heard on auscultation, especially with enzymatous patients. Okay? Coarse breath sounds, bronchi, mucus in the airways, diminished breath sounds, again, chronic bronchitis versus emphysema. Chest hyperinflation, air trapping, distant heart sounds. Okay? Normal bronchitis. A lot more presence of the bronchial markings. Okay? Enlarged heart. If you notice, and later on there'll be one with emphysema. These aren't as hyperinflated, but you can kind of tell a little bit of flattening right there. With emphysema, you'll get really long hyperinflated lungs with flattening of that diaphragm. There should be a picture here in a little bit. Emphysema, destruction of the septa occurs in distal terminal airways, involves both airways and the lung parenchyma. It will stretch the tissue when it talks about lung parenchyma, because again, those little air sacs start expanding and getting lazy. They start expanding. You start getting hyperinflation, so the little airways will start pushing out that lung parenchyma. Okay? Minimal cough, little to no sputum. Their main complaint is they can't breathe. Thin, can't eat because they're working so hard to breathe, using so much energy to breathe. Erase burial chest, that's more for bronchitis. Minimal wheeze, accessory, muscle use, tripod position, pursed lip. It is the old pink puffer and blue bloater. Please tell me you've heard that.
Yes.
Emphysema and chronic bronchitis. This is a good picture. As you can see, that's my boy right there. Pure emphysema. Every day. Every day. Okay? So terminal bronchial, asinus. Okay? Respiratory bronchial, alveolar ducts, and alveoli. Just expand, there's not a whole lot there. Large airways, trachea, bronchi, mucus production all throughout here. Bronchi. There they are. I always wondered if those were just tumors or. I need a new picture, that's awful. My boy Bob and his emphysema. Alright, another thing, with emphysema, one thing I don't like seeing is, the radiologist can call it, if you just diagnose emphysema based on a chest x-ray, it's very hard to do unless you see big blebs. A lot of times, please refer to it as hyperinflated lungs, okay, or elongated lungs, big, long lungs, like this, okay? Flattened diaphragms could be suspicious for emphysema or consistent with emphysema signs, not just he's got emphysema. Unless he has blebs, then you can call it emphysema. Wall of bleb. He's got one big one there, another one, you can see the outline right there, right there. The next couple slides just kind of go over the airways, what an x-ray may look like. Again, hyperinflated, loss of lung tissue and air trapping, twice the size of normal lungs. Normal, long. Okay? Emphysema. When we talk about dead space of air, all these little black holes, that's dead air. That's dead space, not doing anything. A lot of times you'll see it in upper airways, but it can be diffuse. You'll start getting, if those little areas get too big, you can form blebs or bullous emphysema that are big dead holes. Okay? Those can pop, causing a pneumothorax. Not fun. Auscultation, decreased breath sounds. Again, it goes back to the prolonged expiratory time, decreased vocal resonance, dry basilar crackles, bibasilar crackles usually, palpation, percussion, that won't do anything. Labs, ABG and CBC. I don't do an ABG unless they're always hypoxic or you worry about their CO2 really climbing. If they've been in the hospital quite a bit and required a BiPAP for emergency cases, there's what's come out now, because with insurance purposes, hospitals are not being paid back for readmissions due to lung disease. Okay, so instead of me putting, in the hospital, intubating you, giving you time to relax and fixing your lungs, there's such thing called a home non-invasive ventilator. I can take care of all your lung volumes, your rate, anything and everything without sticking a tube down your throat. Okay, that is in order to try to give your lungs a break during the night, even sometimes during the day, if you are that severe. That is for chronic hypoxic and hypercapnic respiratory failure. CO2 greater than, I think it's 50, 55 is their requirement for a home vent. So the patient comes to you or their family says, hey, Uncle Bob here acting a little confused. He's already on 4 or 5 liters of oxygen. You might want to check that CO2. Okay. Gold guidelines, we'll go over that in a second. Spirometry, she'll go over that. Increased total lung capacity. Again, total lung capacity. Normal lungs. You get hyperinflated lungs. Here's 100%, 110, 120, 130. You lose that recoil. You lose the elasticity. So take a breath in. They're already starting at 120. They're going to trap a lot of air. That functional residual capacity, when you take a breath in just a very tidal volume, you're going to trap a lot of air just doing that right there. Residual volume of air remaining in the lungs after a maximal exhalation. Decrease the LCO, so how well your lungs are perfusing. This right there, your lung function may be decent, your lung capacity may be decent. This happens a lot of times in younger patients because they have their age going for them. Spirometry may be mild to moderate, lung capacity may be okay, their DLCO may be 60%. Okay? They could have horrible emphysema. Those air sacs are not working the way they should. So they're going to get really short of breath doing activity. Their lungs can't produce fast enough to keep up with their oxygen needs. We go back to COPD staging, mild, moderate, severe, very severe. Greater than 80, 50 to 80, 30 to 50, less than 30. And the symptoms, I keep pointing to this like you guys know what I'm doing. Chronic cough, symptoms as far as at each stage, that's something good to know. Here is the new GOLD guidelines. It takes into consideration how not only just what stage you're at, but your exacerbations. Because you could be stage 3 and be pretty stable for a long time. But you could also be stage 3 and be in the ER every 6 to 8 weeks. Okay? So this looks at not only are you mild, moderate, severe, very severe, where are you on the assessment, right? Do you have symptoms at all? How many exacerbations do you have? Do you have a lot more symptoms? Do you have more exacerbations? Right there. None per year, 1 per year, greater than 2. So when you diagnose someone with COPD, you can put them in this GOLD A, B, C, D. This is the modified dyspnea score. That's it right there. No symptoms on exercise, shortness of breath when hurrying or going upstairs. Walks slower than most people, has to stop every 15 minutes or so, stops every 100 yards, doesn't get out of the house. Treatment, someone's going over treatment, right? Treatment, treatment, treatment. Oh, that's exacerbation treatment. Nebulizers and steroids and possibly antibiotics. If they have a nebulizer at home, what I do, how to be proactive, I try to keep them out of the hospital as much as I can. I have them in the hospital, this is my speech. You're going to get a breathing treatment every 4 hours whether you like it or not. At least give me 3 a day, if not 4, while you're on my steroids. Symptoms, treatment, vaccination, pneumonia, home oxygen, testing. When they come to your office, have a pulse oximeter in your pocket, test their oxygen levels. If they complain that they're dyspneic on exertion, do a 6-minute walk test. Walk them up and down 6 minutes and see what they do. Complications, pulmonary hypertension, pulmonale. Pulmonary hypertension, if you're noticing their symptoms are out of proportion of what your data is showing, look somewhere else. There's got to be another reasoning behind it. Get an echo, okay? On an echo, you're looking at tricuspid regurg and their estimated RVSP, okay? Systolic right ventricular systolic pressure, mean pulmonary arterial pressure. Normal is around 35. 30, 35. You start to worry when it's in that 45, 50 and above range. It's right here. Less than 25%, greater than 90% 5-year survival rate. Greater than 45%, less than 10. That's on an echo. It's a very rough estimate. If you're that concerned, send it to a pH specialist or a cardiologist and have them do a right heart cath to get adequate pressures. Pulmonale, pneumothorax due to formation of bulla. Oh, let's go back there. Ask questions. What inhalers are you on? And obviously, are you using them right? Have you been prescribed oxygen? Trust me, they'll walk in your office, 70%, where's your oxygen? It's in the car. Yeah, they'll do it to you every single time. How often do you use your inhalers? Do you even have a nebulizer? How often do you take these? Another thing, I don't know what Tassie's going to say about steroids. Everybody's different on steroids. Urgent care, ER, their typical swindle is to put you on high dose for short course, 63, 50 for 5. That's the way they do it. That's fine. Urgent care will do the same thing. I don't do that. I'm not a big fan of jacking someone up, getting them high dose, and throwing them off a cliff. Play nice with lungs, okay? It's going to take a hit. I do taper. Sometimes a little menthol nose pack to get them through it, but if you're a bad lunger, you're going to need like 60 for a couple days, 40 for a couple days, 20. Studies have shown it doesn't matter. Short term, taper, doesn't matter. You will figure them out once you get into practice. Okay? Again, because patients, some lungers will know what works best for them. Last question, do you have a pulmonary physician? Because they probably do. You're good. Restricted, let's do this. Questions? You get two.
I have a question. So besides just like appearance and like signs and symptoms, is there another way to tell between emphysema and chronic bronchitis?
Ask questions.
Okay.
Cough more. You cough, you wheeze. No. Always short of breath. Right there should tell you, maybe. The way they sound. Okay? You'll get a fat emphysema patient, that's not a shame.
Well, RSP was COPD, and I told him there's different kinds, and he was like, well, which one am I? And I was like, you're mild right now, so it doesn't really matter which one you are.
COPD, it's chronic asthma because it changes the airways. It becomes a chronic, non-reversible thing. Okay? I apologize, I've not looked at this lecture in a while, so we're going to run through it. I actually love restrictive lung disease because it's so much different and interesting than your typical asthmatics and COPDers. It's difficult to figure out. Some of them are very sad. I'll show you some CAT scans. Restrictive lung disease. The first couple, board questions. Coworkers pneumoconiosis, coal mine dust. If you see that in any of your questions, just go to the answers. Just go to the answers and just search for pneumoconiosis. Okay? Exposure over years, at least a loss of lung function due to chronic fibrosis. Coals inhaled, inductive macrophages, release reactive O2 species, trigger release of cytokines. It changes the tissue. Okay? Cough, sputum reduction, small nodules that predominate the upper lungs, treatment, oxygen, rehab. Silicosis, it's in this area, I promise. Prolonged inhalation and retention of silica particles. Silica is mostly in crystallized quartz, ceramics, brick making, stone masonry, sandblasting, and glass. Hallmark lesion, silicotic nodule. Small rounded opacities in upper and mid lungs, 3 to 5 millimeters. First of all, hilar lymph nodes and may calcify or erode the airway. Lung parenchyma is subsequently involved, usually upper lobes. It goes back to taking a good history. Where were you brought up? Where were you around? What do you do for a living? What do your parents do for a living? Tachypnea, fine crackles, shortness of breath. We'll need an open lung biopsy for definitive diagnosis. Treatment, avoid exposure, stop smoking, lavage if needed. This is another thing. Even after you stop exposure to it, it can happen years later. It can still happen. Silicosis. Skip it. There it is. Three to 5 millimeter nodules in the hilum, mostly upper lobe. Asbestosis, you'll get asked about this a lot. Make sure to ask about military service, where they were stationed. I mean, not as much now, but you get that 89-year-old guy asking. But if they have asbestosis, they know by that point. Interstitial fibrosis, prolifignates similar to silicosis, can be seen 50 to 20 years after exposure. Renovating destruction of old buildings, shipbuilding, or just working on a ship, period. I've had stories of old military guys working on subs that had a metal bar that just banged poles and they just see it fall. Okay. Dyspneic exertion, non-productive cough, chest X-ray fibrosis. This should be in bright red for asbestosis. That will be, if you see that on a question, just go to the answers and choose asbestosis. Full plaque. I mean, read the rest of the question, but most likely. Don't take my pass on the test. Make sure to get a CT to evaluate the plaque. A lot of times for disability reasons, some will go off of just the CT alone. Most of the times you'll have to get the open lung biopsy. Treatment, oxygen if needed, pulmonary rehab. You gotta stop smoking. Risk of lung cancer in non-smoking asbestosis worker, 5.2. Risk of lung cancer in smoking increases 53-fold. Increased risk of developing mesothelioma. You've seen the law commercials. The pleura, bronchogenic carcinoma, and TB. Make sure to do regular follow-up, chest X-rays, high-res CT. There you go. Hopefully I have a CAT scan. I'll put a CAT scan next time. It'll better show you the pleural plaque on the side. Sarcoid. This is we see it, I feel like we see it all the time. Sarcoid doesn't play by the rules. It doesn't come with a manual, which it did. Multi-system granulomatous disorder of unknown etiology. Unknown etiology. I have no clue why it happens. No one does. Okay? Can affect lungs, lymph nodes, eyes, skin, liver, spleen, heart, joints, nervous system. Most common in young African American females and Northern Europeans. I promise you right now, I can't tell you how many little old ladies I've diagnosed with sarcoid because they've been worked up for something else. We have abdominal scan, they have tons of little nodules on the bottom part of their lungs, and it's sarcoid. Okay? Sarcoid always doesn't necessarily have to be treated based on symptoms. Exaggerated cellular immune response manifested by non-caseating granulomatous inflammation. Red. It needs to be in red. Hey, I wrote that in. See this term in the PATH report. Remember this. Okay, non-caseating or cavitating granulomatous inflammation. Or cough, shortness of breath, fever, chest X-ray, bilateral hyaluronopathy, interstitial infiltrates, or both. Get a chest CT for closer evaluation. Based on pathology from, it's hard to do it from a transbronchial biopsy. Most likely it's an FNA of a nodule. Lung nodule, you can get them on your skin as well. I've had that happen maybe once or twice. Treatment, 90% respond to steroids, 56% have spontaneous remissions. Again, sarcoid is not played by the rules. You will have someone that gets one flare-up, that's how they're diagnosed, never comes back. You will have a flare-up all the time. I've had a lady that was on 60 milligrams of prednisone for 6 months before I could taper her down. And I had to taper her down so slowly because she kept relapsing. 2.5 milligrams every week, every 2 weeks, because she just relapsed. Or they may never have any symptoms whatsoever. Baseline labs at time of diagnosis. PFTs, you're going to do that pretty often. BNP, it does affect the heart. Echo, 24-hour urine calcium, bilateral hand X-rays. It starts to affect the wrist joints first. ACE level will be elevated and refer to ophthalmology. It can affect eyes. Not an optometrist, ophthalmology. Follow patient with serial PFTs, chest X-ray, high-res CT. That's sarcoid. You will see that and think, oh, it's pulmonary edema. Maybe not. That's forward-looking pneumonia. Maybe not. You see this, please be included to a pulmonologist. Sarcoid. Tons of little scattered nodules. You see this, you also, someone's going to see that doesn't do lungs, and say you got metastatic cancer somewhere. History, exam. NSIP, non-specific interstitial pneumonitis. Younger patients, onset's gradual, 6 months to 3 years before diagnosis. Symptoms: cough, weight loss, breathlessness, diffuse basilar crackles, diffuse symmetrical ground glass changes with or without traction bronchiectasis, confluent homogeneous pattern. Honeycombing is rarely seen on a high-res CT. Honeycombing is very important to differentiate NSIP to UIP. Again, non-specific interstitial pneumonitis versus UIP, usual interstitial pneumonitis. Treatment: steroids. Some respond well, some don't do anything. But it's usually high-dose steroids for about 6 months. NSIP, going back, ground glass changes with or without traction bronchiectasis. Confluent, homogeneous. You get these kind of lot of changes throughout. It's not just in one area, not on the periphery, it's throughout. Ground glass is just what it means. You can tell the difference between airway and it starts to change. It honestly looks like ground up glass, especially even down through there. Beautiful. Where that little arrow is, traction bronchiectasis. The scarring is pulling that airway, leaving it open. COP, cryptogenic organizing pneumonia, formerly known as BOOT, bronchiolized organizing pneumonia. Just what it is. Organizing pneumonia is most common in non-smokers, roughly 56 years old. Short duration, less than 3 month history of shortness of breath, dry cough, malaise. Chest infection that has slow to resolve after several rounds of antibiotics. Get chest X-rays. If it is not responding, get a CAT scan. Those pneumonias will jump around. One time it'll be left lower, you treated antibiotics, they got better for a few days, they're in your office 2 or 3 weeks later, and they get pneumonia up top. Get a CAT scan. Maybe normal or if you have crackles, patchy consolidations, or even a solitary mass. Areas of consolidation with bronchograms, ground glass opacities. Again, these areas can migrate spontaneously. Needs transbronchial biopsy or open lung biopsy. Treatment: long-term steroids over months, maybe 6 to 12 months of therapy. Get a high-res CT. High-res CT, normal scan is what, 5 to 3 millimeters. High-res is about 1 centimeter cuts. It gives you a better idea of the lung parenchyma, lung tissue when you do that. It looks much better than emphysema. No fun. Here's the bad one. UIP or idiopathic pulmonary fibrosis. Diffuse lung disease of unknown etiology. That's why it's called idiopathic. Us idiots don't know what happened. It just happened. Involves the interstitium of the lung, the fibrous framework of the lung. Onset of 9 to 24 months, most common in males. Mean age around 65. Fine basal, late inspiratory crackles, peripheral reticular shadowing on the chest X-ray. High-res CT, I'll show it to you in a second. That's when you get into the honeycomb in the periphery. The way patient will need an open lung biopsy or VATS to diagnose. A VATS, video assisted thoracic surgery. Pulmonary fibrosis, up until November 2015, it was at time of diagnosis, you got 3 to 5 years to live. At time of diagnosis. There's no treatment, there's oxygen, get your things in order. There's 2 medicines that came out, I think they're on this lecture. One is pirfenidone, or Esbriet. Yep. The other one is OFEV, or Nintenibab. I call it Nintendo. Makes my rep really happy. They are not curing medicines. They are hopeful medicines, as in, I hope we can slow down the progression. It's going to get you one way or another. These medicines are about $100,000 a year. They've gone up. They were 95, 96, now they're about 100, 105. That's IPF. He's got IPF and emphysema. But if you look in here,
Keep going down. Yeah, you have more in each one.
yeah, there it is. We're back up. All right. Very poor prognosis, stable versus decline. I always tell patients there's about three different ways this could go. You get it, and it's a slow decline over the next couple of years. That's it. The ladder effect, stepwise effect. You do fine, you crash. You do fine, you crash. Fine, you crash. Or you do fine, you're done. Median survival 2.5 to 3 years. Time of diagnosis. Yeah, 2015. OFEV, Esbriet. In the periphery, you will see this is not emphysema. You get this honeycombing pattern in the periphery of the lungs. Honeycombing is a key word. That's it. What else you got? That's it. That's restricted lung disease.
What did you say the other acronym is for that? The idiopathic
Pulmonary fibrosis. Oh, UIP?
UIP.
Yeah, sorry. Usual interstitial pneumonitis.
What was the OLB for diagnosis?
Oh, open lung biopsy.
Open lung.
So with insurances to approve those medicines, some insurances will go off the chest CT if the radiologist, some radiologists won't do this, you kind of have to call them and ask them, and some do, some don't. If they mention that honeycomb pattern and say suggestive of UIP or idiopathic pulmonary fibrosis, but if you question it, get an open lung biopsy. A bronchoscopy, a transbronchial biopsy is not going to cut it. That transbronchial biopsy, the tissue is way too small for definitive diagnosis. Other questions? I can't believe I taught this one. What else you got? I don't have any more. I don't have anything else.
Does anybody have any questions?
I have just like a kind of general one. So when should we really be concerned with a patient who comes in presenting, you know, like an adult onset asthma symptoms versus something that might be maybe more malignant that we would be afraid of? Like, how do we go about differentiating those, you know?
Depending on all their symptoms that are going on, really, you will have a lot of, especially females for some reason, they tend to get it later on in life, at adult onset at 45 to 55. Give me history to say, when did it start happening? I had asthma as a kid, grew out of it, I've been fine for the last 40 years. Now I'm having more symptoms. More of a malignant issue. Again, it goes by symptoms. You just have to work with it for that. If it's not an asthma, you would start to see it.
Earlier today, our teacher asked like if we've been told when to send to a pulmonologist. Do you have any like hard and fast rules of when to send somebody to you guys, or?
So, don't wait. Okay, when I say don't dink around with lungers, don't do it. Don't do it. Those IPF patients, they'll come to you with shortness of breath. Okay? I've had some that have PCP and I'll name it down, go you go. Oh, you got asthma, you got COPD because you smoked 10 years when you were a kid. They don't do a chest X-ray, they don't do a CAT scan for years. You got IPF, that's 2 out of 5 years that you don't know. When you have tried giving them inhalers, the symptoms are still not well controlled, considered pulmonary referral. Because I feel like sometimes we get it too late in the process, or that sometimes patients are just giving whatever inhaler is new out, and this is really not the best approach for them. You know, new guidelines are pushing the LAMA combos. She'll go over with Bevespi, Noro, Stiolto. They have more bronchodilation, more emphasis in these patients. They don't need the steroid. They just can't breathe. Right? They don't have a lot of information. All their little guys are just quick working. You're trying to max out whatever they got left. Bronchodilation, that anticholinergic, decrease smooth muscle restriction, open them up. You gotta give them every chance they got. Okay. What else? Where's my inhalers? She's got them. It's alright, you're good. She's good. You're good. Yeah, number one thing, really, make sure to educate your patients from a PA standpoint. That's the number one thing. Know how to use the inhalers. Watch them use it before they leave the office. I've had some pretty, I can't say really super quick. Yes, she's in the, they do it like this and it's happened. What else?